Hello, I'm Norman Swan. Welcome to this programme on beating bowel cancer, prevention, detection, treatment. And we're coming to you on Rural Health Channel 600. Nearly 300 people a week are diagnosed with bowel cancer, and tragically, for a disease that can be detected when it's curable, bowel cancer still has a very high mortality rate, especially for people living in rural and remote Australia. This programme will help you to reduce delay in diagnosis in your patients and reverse the appalling statistics in rural and remote communities. We'll also clarify additions to the National Bowel Cancer Screening Programme from the new 2012 budget. This is a professionally accredited programme from the Rural Health Education Foundation. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But let's meet our panel. Cameron Bell is a consultant gastroenterologist at Royal North Shore Hospital in Sydney. Welcome, Cameron.
Good evening. Thank you.
Cameron's also Director of Bowel Cancer Australia, a member of the Programme Advisory Group of the National Bowel Cancer Screening Programme, and Chair of the Working Party on Clinical Practice Guidelines for Surveillance Colonoscopy, and that's for Cancer Council Australia. John Bronger is a community pharmacist with over 30 years' experience. Welcome, John.
Thank you, Norman.
John was the National President of the Pharmacy Guild for 11 years and is currently President of the Pharmaceutical Society of Australia's New South Wales Branch Committee. Sally Coburn is a GP and health advocate with many years' experience, currently working in suburban Melbourne. Welcome, Sally.
Thank you.
Sally's involved in community health issues, health policy and education at many levels. She's a presenter on Melbourne Radio 3AW with Talking Health and is an ambassador on bowel cancer, aren't you? And we're going to see an example of that later on. Tammy Farrell is an experienced registered nurse and nurse advisor for Bowel Cancer Australia. Welcome, Tammy.
Thank you, Norman.
Tammy has qualifications in nutrition and is the Managing Director of Core Health Consulting and author of The Real Man's Toolbox. What's inside The Real Man's Toolbox?
The Real Man's Toolbox is a DIY health manual for men.
Right. And the main tip is?
Main tip is to look after yourself and to see your GP.
Right. And ignore man flu, but not anything else. Tammy works with rural and remote mining communities and blue-collar industries in general as a health consultant for employees. James St John is a gastroenterologist interested in population screening for bowel cancer and familial cancer. Welcome, Jim.
Good evening, Norman.
Jim was Director of Gastroenterology at the Royal Melbourne Hospital, a Senior Clinical Consultant in the National Cancer Control Initiative, and has been based in the Cancer Council Victoria since then. Jim is a pioneer of national bowel cancer screening from its inception, has been pushing hard all the way through. So welcome, Jim, in particular. Welcome to you all. I mean, where does bowel cancer sit, Jim, in terms of mortality? I mean, it's just ridiculous. It's up one or second or third.
It's second. Lung cancer causes most deaths, followed by bowel cancer.
I mean, it's outrageous.
Yes, over 4,000 deaths each year.
What should it be? I mean, if we were actually doing our job and getting early detection going according to current technology, what could we get it down to?
I'm an optimist. I believe that we could reduce the mortality down to 2,000 or 1,000. It's going to depend on participation, whatever the program is. The population screening program, the special programs for people with increased risk, families with very special risk. But this is a cancer that lends itself to screening. We can detect these cancers at a curable stage with screening tests, well before they cause symptoms.
And Cameron, why the rural disparity? Is it late diagnosis?
I don't think that's clear, Norman. I'm sure that access to resources is an issue. I'm not sure, James, about participation in the bowel cancer screening program, whether that's substantially different between
participation certainly in the outer regional and inner regional areas is higher than in the major cities.
So the difference is...
But the survival rates are very different. There's a gradation from the rural through to city.
So it may well be ready access to specialised services, at least as one factor.
And Indigenous communities, Cameron?
Well, the rate of the incidence of bowel cancer is lower than in non-Indigenous communities. There are a couple of confounding things. There's a higher rate of cancer of unknown primary in Indigenous Australians, and I suspect that a goodly proportion of that is bowel cancer that goes undetected and unlabelled.
And uninvestigated, presumably.
And potentially uninvestigated, yes.
And Sally, the risk factors?
Well, the risk factors are being over 50, the risk factors are having a family history, some of the conditions like ulcerative colitis and Crohn's disease, of course, and being Australian.
Does Crohn's
living in Australia.
I thought Crohn's disease didn't raise the risk. Is that?
No, it does.
It does?
Crohn's disease and ulcerative colitis are two determining factors that we want to watch for.
And
So
what about?
it does. It's not as much of a risk factor as ulcerative colitis, but in the segments that are affected, so anybody with more than about a third of their colon affected by Crohn's disease, and patients with severe anorectal Crohn's disease are at an increased risk.
And what about lifestyle factors, Tammy?
Lifestyle factors in terms of physical inactivity, high alcohol consumption, and standard dietary guidelines that people follow can put a person at risk by around 70%.
But I thought, the vegetable story, the roughage story had been disproven.
No, fibre is important, but we're finding that high red meat intakes have studies
So
have
it's more
shown
that
that there's
vegetables stop,
significance.
reduce your interest. There's a concomitant reduction in red meat. It's more
Yeah,
the
well,
flip
that's
side.
right, and that's what goes with the red meat as well. But we'd be looking at trying to limit to around 500 grams of red meat per week.
And, sorry, Jim?
Smoking, Tammy?
Yes, and obviously smoking is one of the big factors that we're trying to really reduce in terms of bowel cancer.
And obviously obesity and type 2 diabetes as well.
Obesity and type 2 diabetes, exactly right.
And that's a growth factor phenomenon, Jim, we think, isn't it?
Yes. Oh,
Yeah, it's
Cameron.
a little bit unknown, and teasing out what's obesity, what's insulin resistance, and what's a consequence of the metabolic syndrome itself is difficult.
And gender split?
Well, it's a bit of a common misconception that it's a male disease. It is slightly more common in men, but by age 75, 1 in 17 Australian men will have developed bowel cancer. There's 1 in 27 Australian women, but by age 85, it's 1 in 12 Australians will develop bowel cancer.
1 in 10 for men and it's now, I think, 1 in 15
Yeah.
for women. It used to be 1 in 14. The figures changed just a little bit.
So it's very common. It's the second commonest internal female cancer, the second commonest male cancer, the second commonest cancer killer, and it certainly kills more Australians than die on our roads.
Tell me about the genetics, Jim, and the associated genetic problems.
The genetics are critically important in a small group. When you look at all bowel cancer, about 3 or 4% of cases turn out to be members of families with either Lynch syndrome, what we referred to as HNPCC, hereditary non-polyposis colorectal cancer, or families with familial polyposis. And this is a situation where we can now do genetic testing in many families, and once the family-specific mutation has been found, you can then offer predictive testing to other members of the family to see whether they've inherited the faulty gene or not. So it's a major problem in a small number of people.
And if you have the gene?
If you have the gene, with Lynch syndrome, because they get cancer at an early age, we recommend colonoscopy starting at the age of 25 or even earlier in some families. And they get fast-track cancers and they need colonoscopy every year. It's a critical situation for them. They get multiple cancers. And some people opt for prophylactic colectomy simply because of the disastrous history within their families.
And familial polyposis, total colectomy?
Is normally total colectomy, yes.
Tell me about the Lynch syndrome.
Well, the Lynch syndrome thing, it's a very complex diagnosis. It's based on family history, and it's based on several generations being involved. It centres around at least one of the affected, one of the people in the family affected by bowel cancer being young, either 45 or 50, depending on which set of guidelines you're trying to stick to. It involves bowel cancer. Bowel cancer is a very important component of it, but it also involves other cancers, other gastrointestinal cancers like small bowel cancer, stomach cancer, hepatobiliary cancer, also gynecological cancers, endometrial and ovarian, and then transitional cell cancer of the renal tract. but it's a complex diagnosis. It's something where familial cancer service is often crucially important in terms of sorting out whether someone's family history is consistent with it being Lynch syndrome.
What's your practice and general practice, Sally, in terms of detecting these sort of families, or it's just opportunistic?
Well, I think obviously in general practice it's really important to remember to have that conversation with the patient, but sometimes they don't know what their family history is because, you know, I don't know, granny died of something, you didn't talk about it then. And it is hard and it is a bit of a detective game, and I think we do need to utilise our births, deaths and marriages sometimes, because a few of my patients have actually discovered that their father did die of bowel cancer in the end and that no one ever told them.
Question here is coming from Michelin, asks, is there a biochemical marker that could be used for early detection?
Well, they're being worked on.
But
they're being worked on. Fecal biomarkers are being developed.
So was carcinoembryonic antigen at one point, or have I got that wrong?
That's a test for more advanced cancer, and it's used to look for recurrence of cancer rather than being for early diagnosis.
But those are a real problem because patients read about those in the glossies and they think, oh, I want one of those blood tests. And to try and explain to them that, no, we're using these as markers of progression is really hard.
Let's go to our first case history. 52-year-old Brenda has just celebrated 5 years post-breast cancer survival, and she reckons she's neglected the rest of her health. Time to get back to looking after herself. She's just read an article in a women's magazine there may be a risk of other cancers, and she wants to know if she's at increased risk of bowel cancer, and she comes to see you, Sally, because you're the ambassador.
The ambassador, well, I'd certainly congratulate her for taking the time out to think about the rest of her body, and I think you can understand she's been staring down the barrel of breast cancer, and that's scary, and she's 52, and she would have received something in the mail at 50, but obviously she ignored it. And this is something that we have to take into account. Some of these people throw away their screening tests. So, to talk to her about what's her risk, and I think that's really interesting because there is some misconceptions about the BRCA gene, and I'd like to, I suppose if I may, throw to my esteemed colleague on the BRCA gene situation, because I think a lot of people worry about that.
Is there an association with bowel cancer with BRCA?
Short answer, no.
Right. Long answer is?
Well, it's complicated, like everything, like everything in medicine, but only 5 to 10% of breast cancers are BRCA positive, and in those families, the studies are divided between whether there's any increased risk or not of bowel cancer.
Well, the Ashkenazi Jews, they've got the terrible Jewish diet to deal with, so it's, you know, that complicates it. Hard
to tease that out. Just before we get off the genetics, Norman, I think it's important to remember the non-FAP, non-Lynch people. So in sporadic bowel cancer, it's been estimated that 30% of it has a genetic basis, but it's a very complicated genetics. It's not simple autosomal recessive or autosomal dominant. I just thought we should...
And multi-gene.
And multi-gene, yep.
So we know more about risk in those families than what the genetic basis is.
Yep.
So just coming back to Brenda, I mean, Brenda is now, she's just a 52-year-old woman who has obviously survived her breast cancer, and she just should slot into the recommendations for people over 50, and I'd send her off, of course, take a history, examine her if she's got those symptoms. I'd get her having a fecal occult blood.
But it is one of the misconceptions that breast cancer is a risk factor for bowel cancer and a risk factor for the family.
So what are the current recommendations, Jim? Where are we at with screening? Because there've been
our national guidelines are that all Australians who are in good health should be in a population screening program based on fecal occult blood testing, unless they have special risk factors. We've discussed ulcerative colitis and Crohn's, we've discussed Lynch syndrome and familial polyposis. And clearly, with the strong family history where there's no definite genetic basis, we base screening on colonoscopy. But for 98% of the population, we would say they should be having a fecal occult blood testing every 2 years. If the test is positive, they should then have that investigated, and that's normally done by colonoscopy.
So that's the evidence base based on randomised controlled trials, which show a 30% reduction in mortality.
Level 1 evidence, 3 randomised controlled trials, many other studies.
But we don't have an evidence-based national screening programme, do we?
We're moving towards it. And it's a huge task to set up a national programme for 5 million people and to make sure that you have high quality, that you're gathering all the data to show what the outcomes are and how efficient the programme is. So the decision was made to start with people who are turning 55 and 65, and then to roll out the program from there. In 2008, it was decided to include 50-year-olds. And you mentioned the budget in May. It was announced that 60-year-olds would be introduced into the program next year. People turning 60 from January the 1st will start receiving their invitations from July the 1st.
And so that's at 5 yearly intervals at the moment?
And yes, and then in 2015, people turning 70 will join the program. And then in 2017, there'll be a start of 2 yearly rollout. But the first thing is we'll have screening every 5 years from 50 through to 70.
And just, you know, these things are so obvious you forget. Why FOB testing?
There's a good reason. Back in the mid-1960s, a surgeon in the United States was doing screening for rectal cancer using sigmoidoscopy. And he said he wasn't finding enough. It wasn't productive. And he suggested that we should use a test for blood in the bowel action. Cancers tend to have low-grade bleeding. And because of that, there was this interest in fecal alcohol blood testing for population screening. A simple test to see who should be having colonoscopy. And the randomized trials were started in the 1970s, early 1980s. So by 1996, we had this level 1 evidence. And Australia moved very quickly. We adopted this as our national guideline by NHMRC in 1998. It was recommended that there should be a pilot to look at the practicality, the feasibility, and the acceptability of this in the Australian population. So we ran a pilot from 2002 to 2004. And then we had the start of the national program in 2006. One thing we found in the pilot was that there were 1,270 people who had a positive fecal alcohol blood test, and 67 of them turned out to have cancer. 5.3% it was when they had their colonoscopy. But in the pilot, it was decided that people who had a strong family history or who had symptoms suggestive of bowel cancer, as assessed by their doctors, should also have colonoscopy, even though their test was negative. And in that group, there were 530, only 2 had cancer. So the likelihood of finding cancer when the test was positive was 14 times greater than when it was negative, even though those people had what we would regard as strong risk factors. So it depends on the age, but between 10 and between a 10 and 20, almost 30-fold increase in likelihood of finding cancer if your test is positive compared to having a negative test. It's a remarkable screening test.
And we've gone beyond, you know, you don't brush your teeth and you don't eat red meat.
Yeah. The test we use is an immunochemical test.
Do a show and tell for us, Jim.
But it's an immunochemical test for human globin. And it only detects bleeding from the large bowel. If you brush your teeth, as you say, that globin is digested and it isn't recognisable when the test is
So show us
performed.
what happens.
People receive this kit in the mail. And this is the package. It includes a letter of invitation. They actually received a pre-invitation letter several weeks before, just to alert them to the fact that this is about to arrive.
And to encourage
Yes.
enhanced participation.
And to encourage them to talk to their doctors if they're not sure whether it's appropriate for them. Let's say they've had bowel cancer years before, they're already having colonoscopy. They should see their doctors and discuss it, and almost certainly phone the information line and opt out. They receive an information booklet. They receive a registration form, and there's a consent form. In addition, they receive the test kit. And this is the kit which is currently being used in the national program. People worry about stool tests, and we keep saying to them, once you've done it once, it's very, very easy. And when they do it, they say, no problem. We worry about smell. They worry about smell. They worry about the fecal aspect of it.
Jim, I think this is where, as in general practice, we can really be useful, because we can actually tell them in advance, when you receive this, you won't have to handle it, you won't have to touch it. And I think it's up to us to do that.
Yeah.
So show us what happens.
How do they collect the bowel action? This is a collection sheet which is placed above the water in the toilet bowl. It's methyl cellulose, it's waterproof for 2 or 3 minutes, it's biodegradable. They have to collect samples from
So it's 2 samples
2 samples.
from separate stools.
Yes, there's no diet needed. There's no need to change medication. All they have to do is to collect the samples. They have a probe, and you'll see there's a red line there. And they have the tube, which contains a buffer, a liquid. And they insert having passed the bowel action onto the collection sheet, they insert the probe down to that depth, swipe 2 or 3 times, and then simply insert. And when that's inserted, that locks. There's a transport tube to protect it, and then it's put in a zip-locked bag. Next bowel action.
And you just put that somewhere cool until the next time.
Kept good, yes. Next bowel action, the same. They collect the sample, and in it goes into its tube, and then that is returned in a reply paid envelope.
With the forms.
Who does the results go to?
The results go to the participant, and when they nominate, and they normally do nominate a general practitioner, to the general practitioner, and of course a copy goes to the central register.
So they'll know to come to us.
Yes.
We don't, yeah.
It's terribly important that people are aware that it is so simple, Norman, because currently less than 40% of people who receive those kits do anything about it. 60% of them end up in the bin, and that's a tragedy. It's a lost opportunity.
What sort of numbers are coming to pharmacies for the kits, John?
Well, it depends on whether Rotary has got a promotional period when they look at it, or it's bowel screening week. But they do come in, or whether a local person that's well known has had bowel cancer. And these are all the triggers, and that's when we feel large numbers of inquiries.
And you have got an immunochemical test as well?
Yes, yeah, this is the one that we currently use, is this one. And
Tammy, show us how this one works.
yeah,
Yeah.
Tanya.
So basically, they will purchase this kit from a pharmacy. Inside the envelope, there will be 2 blue plastic bags, 2 brushes.
So these plastic bags have a different function from
Yes.
the plastic that we just saw Jim showing us.
So what happens, and there's quite a good in-depth
So to speak.
instruction manual here, all full of little pictures, so it's quite easy to use. But going to the toilet, you would put your used toilet paper in the blue plastic bag, then get the little paintbrush and swirl that around into the toilet water. You don't actually have to swirl it into the stool itself, but the occult blood will attach from the toilet water onto the bristles of this brush. Then you take the little sample card that's in here, and stool number 1, you would wipe that on this little test strip here, put this in the blue plastic bag, put it in the bin, seal that over. Then the second time you go for your next stool, you would take out the second brush with the second square, wipe this on here, seal that over, place this in the bin also, and then you would put this in the envelope that is returned to the pathology unit, and the results will come back 2 weeks later to the GP in which the patient has requested, and to the patient themselves in order to follow up whether the test was positive or negative.
So Norman, if I could, the bowel screen is something that Bowel Cancer Australia set up in collaboration with the Pharmacy Guild and with the supplier of the test kit, just as a simple alternate pathway for people who weren't receiving kits from the government.
And we haven't found many customers, patients, having difficulty with the process. It's very easy to follow, and we haven't had people coming back and saying, "Oh, I messed it up, can I have another kit?"
We also find that 83% of those who have done the test would definitely do it again because they realise how simple it
How
is.
easy it was.
And that's the real problem. The majority of my patients, when I press them, say, I just didn't do it because I just didn't want to know. I didn't want to know whether I had to touch it. May I just ask a question, though? We've got the 5-yearly, eventually the 5-yearly screening, but isn't the NHMRC screening in general practice that we do it every 2 years over 50? So what do we do it in between?
But the national program's moving to 2 yearly.
But in the meanwhile, we in
in
general
the-
practice should be doing it 2 yearly?
Yes. And they're advised to have that done every 2 years or 2.5 years.
So is the colonoscopy that follows a positive fecal occult blood test free?
No, the test in the national program, the test is free, but then it's usual care. so they can be referred to a public hospital or they can be referred privately. And it's up to the general practitioner to decide.
So, Sally, access to colonoscopy?
Well, this is a problem. I mean, it's even hard enough in the city, but I imagine in rural areas it must be very difficult, especially in the public system. Many of my patients just say they can't afford to go private and they can't afford to wait to go public. So it's a real problem.
It is something that Bowel Cancer Australia, we get a lot of inquiries from patients who have been on the screening program, and their concern is that if they are remote, they're on a 3-month waiting list for some people, or 4 months when they've had a positive test.
Questions coming from Robert. How long does it take for colon cancer to develop from a harmless polyp to the first stage? So just give us a sense of the natural history here, because people are focused on polyps.
Yeah.
And not all polyps are worrying.
No, not all polyps are worrying. There's a histological type of polyp which can almost be dismissed as soon as small distal hyperplastic polyps can almost be ignored.
And are not an indication for repeat
not
colonoscopy.
an indication for repeat colonoscopy. That if that's all that's found at a colonoscopy, that patient goes back to being the risk they were before that polyp was removed and analysed. So an adenoma, that type of polyp, adenomatous polyps, generally take at least something in the order of 8 to 10 years if they're going to become a cancer. And we've got to remember that not all polyps will. A rough estimate would be that in good hands, colonoscopy will detect adenomatous polyps in probably as high as 50 or 60% of people. But over their lifetime, only 5 to 8% of Australians will get bowel cancer. So many polyps, we just have to take polyps off without knowing whether that was the polyp that was going to become a cancer.
And another question from Craig from Broome asks, is there any connection between diverticulitis and colon cancer? And Janet, a nurse from Newcastle, asks, can the symptoms of diverticulitis confound the diagnosis of bowel cancer?
There's no link between diverticulitis and bowel cancer, and yes, like a lot of other gastrointestinal conditions, including irritable bowel syndrome and hemorrhoids, there's huge symptomatic overlap.
I mentioned before that the tests are colon specific. Many people who have a normal colonoscopy as part of their investigation are then advised to go on to have a gastroscopy, and it is entirely inappropriate.
Yep.
Why is that? The colonoscopy hasn't gone that far? You know what?
Yeah. If the bleeding is
long
only
enough.
arising from the large bowel, it's quite inappropriate with an immunochemical test for them to have a gastroscopy. It's an unnecessary burden for them.
Yep.
Unless they've got symptoms.
So this is where you found bleeding. You don't find anything in colonoscopy, and they say, oh, well, maybe there's something in the tummy, which there won't be because it'd be degraded.
We assume it's bleeding from, say, from hemorrhoids or from diverticular disease or from some other innocuous cause.
Damien's 47. He's the only lawyer in a small rural town. He comes to see you, Sally, wanting a checkup. He's got no symptoms, family history of ischemic heart disease, but no family history of cancer, and he wants bowel cancer screening.
He wants bowel cancer screening. Well,
yes, doctor, and now.
Yes, well, I also know that...
And by the way, he's a litigation lawyer.
Yeah, I know. He used to work for Ambulance Chaser and Ambulance Chaser, so I'm told. Look, I'm not going to bow and sort of play defensive medicine. I'm going to treat him properly, except that he's 47. The national guidelines say I should start my screening at 50 if he's got no family history. But I suspect, my view, I treat people, not national guidelines. And I see no skin off his or my nose to prescribe a fecal occult blood test. I would not advise him to have a colonoscopy, but I would advise him to have a fecal occult blood, despite the fact that he's not 50.
What if he says to you, Sally, that it's an inaccurate test, it's got false positives and false negatives, he wants the real thing?
I want to do the fecal occult blood first, and let's discuss it after that.
And you would say also the colonoscopy has false positives and false negatives.
But not in the good Dr. Bowell's hand.
No, but it's a good point, Norman, and people, James is quite right to bring it up, people presume that colonoscopy is perfect, and it's not. We've known for at least 15 years now that there is a thing called a missed lesion, and that it should be discussed with every patient having a colonoscopy as one of the potential complications of the procedure.
So Damien then says to you, Sally, but, you know, I get some itching in my bottom and there's blood on the toilet paper and sometimes in the spattering in the pan.
Well, I would examine him, Norman. I would get on the gloves and I would do as good Sir Edward Hughes taught me, and I would put my finger in before I put my foot in, as long as he didn't have pain. But the thing is, with the spattering at the end, with the itch, he's probably got abrasions. I would treat those clinical signs that I saw.
But you might not see anything.
Well, that's absolutely
true,
true,
I
isn't
may
it,
not.
Sally?
So,
I may
nothing,
not see
so there's nothing to feel. You can't see anything. You think it might be hemorrhoids. There might be some hemorrhoids there. There's no fissure. And,
Well,
he's a litigation lawyer.
Yeah.
He's going to have a bit of excoriation from the
I would've
itching and the
thought.
scratching, and he should stop.
So what's the commonest cause of perianal itch?
Pruritus ani, Latin for itchy bum.
Right.
And
that's
he
not a cause. That's a nice fancy description.
It's usually due to over-vigorous use of toilet paper and irritation of the perianal skin from the paper particles.
So we treat that first and then get him to do his fecal occult blood. Get rid of the possible
Buy a
causes.
bidet and then move on.
That's it.
At the same time, you would want him to understand that his risk for bowel cancer is rising progressively as he gets older. If he's going to start screening now, he should continue on a regular basis.
But do you want to just have a look at the absolute risks at this age? I mean, let's just have, we've got a graphic here, I think, of absolute risk. So at 45, 50, so it's about 1 in 300.
He's
approaching.
almost at 50.
In the
So
next
his-
5 years, yeah.
His likelihood of getting bowel cancer in the next 5 years is 1 in 300. In the next 10 years, 1 in 100.
Are you saying that he's going to pressure us for a colonoscopy?
So, well, I'm just trying to get to the point where my understanding is that if you've got symptoms, you don't proceed to FOB testing, you proceed to colonoscopy or sigmoidoscopy.
But not in the case where we've got symptoms we can treat. If he's got something we can treat and get rid of the symptoms, then we check the fecal occult blood. So give him some anti-itch cream and some anti-hemorrhoid cream, and then test his FOB. I'd also do his iron to see whether he was iron deficient, I think.
But some people who've got symptoms, you're right, they do need to have investigation for the symptoms right through to colonoscopy. But once that's been sorted out, he would then need to have ongoing screening. And normally, in his case, it would be based on fecal occult blood testing, unless you found an advanced adenoma at the colonoscopy or some special risk factor.
But important to differentiate investigation of his symptoms, history and physical examination to begin with, and whatever else, and the issue of screening, and they're two separate discussions.
I'd also call in Tammy to look at his primary prevention program.
So what are you going to do for him, Tammy?
So
Having been reminded of that, thank you very much.
considering he's a solicitor and possibly sitting for the majority of his day, I'd want to be looking at...
Well, he's fidgeting because he's got an itchy bum.
Well, that's true, moving on the seat. But looking at what his average day looks like, what's his dietary intake like, how sedentary is his lifestyle, is he a big drinker, does he smoke? Just looking at all the things or the parameters that we could change to actually minimise his risk. And if it is hemorrhoids, are you drinking enough water? Are you having too much fibre? If you're not hydrated well enough, causing potential hemorrhoids.
Speaking of his risk factors, we did know that he has a family history of ischemic heart disease, and I think the thing we could suggest to him is we can actually maybe help both his risk factors here or whatever with aspirin. And I believe, Jim, there's some work done in aspirin and bowel cancer.
Mounting evidence now that low-dose aspirin, 75 or 100 milligrams per day, reduces the likelihood of development of adenoma, of cancer itself, and of death from bowel cancer. And also other cancers, interestingly. But bowel cancer seems to be the one where there's the greatest effect.
Won't that cause problems with the fecal occult blood test or not? No?
Not with an immunochemical one.
Upper GI.
The bleeding is gastric. That
Yep.
bleeding, that blood will be broken down and it won't be recognised.
Are you getting many people coming in asking for low-dose aspirin for their cancer, John?
No, not really, but we're finding that a lot of people over 45 now are taking low-dose aspirin as a prophylactic. For certainly they're, to prevent stroke and other areas associated with their health.
Angela,
So it's a common feature now.
So Angela, a general practitioner registrar from Beauty in Victoria, asks if we screen biannually between government tests, is this covered by the general rebate with Medicare, or is the patient out of pocket? Or can the GP order the test like a normal pathology test?
I'm certainly ordering it like a normal pathology test, and I haven't had any complaints from my patients, so I'm presuming they're getting a Medicare rebate, I have to say.
So you send them off to the pathologist and they give you an FOB kit?
No, I have it in my cupboard. And can I just make a really big point? They have a use-by date on them, and sometimes it's quite short. And if the patient goes away and doesn't do it for 6 to 8 months, that can actually pass its use-by date.
So hold on a second, so you've got it in the cupboard and it's sent off to the pathologist and they bulk bill, or what?
Yeah.
Leo from Beauty, I presume this is the GP supervisor of Angela, asks what's the false negative rate for bowel cancer screening?
For fecal
With the,
occult, for
yes,
fecal
with the
occult blood
immunochemical test we're using, the sensitivity for cancer is of the order of 85 to 90%. So it's far more sensitive than the Guaiac tests, which were used in the randomized controlled trials. They missed about 50% of the cancers.
Right. So that was sensitivity or the specificity?
This is sensitivity.
And the specificity?
So
That's the false, specificity is false negative. I always get this wrong. The specificity is false negative, isn't it?
It's,
Here we go. Clinical epidemiology equation.
Picking up-
Shouldn't have asked it.
No, it's the performance in people who don't have
Yeah.
disease. So how often does someone who's healthy get a positive test?
Yes.
And it's of the order of
Well, no.
two or 3% with the test we're using. In that, they don't. This is a test for blood, and we're talking about detection of neoplasm. It's a remarkably
I think
effective
Leo's
test.
asking how many cancers are missed. What proportion of cancers are
About-
missed?
We, in the national program, will have to wait to see what happens over the next few years, but it's of the order of 10%. We believe.
So the next case study is Joe, who goes to see you, John, in his local pharmacy to buy an FOB kit. He's heard he should get tested, but he's really worried because his grandmother had bowel cancer when she was 45.
Well, I'd see no advantage, no disadvantage in giving him a test kit, selling him the test kit, and of course, at 45, I mean, it doesn't meet the criteria, but in a sense, there's still about a 1 in 600 chance, and they're better odds than lotto, and a better prize if he's found that he's got a problem, and he's a bit of a family history in it. Maybe, Cameron, you've got a better idea of it.
So how do you make sense of this family history, Cameron?
well, I think you'd want to look into it. I mean, it's bowel cancer. His grandmother was only in her mid-40s when she got bowel cancer, and that's regarded as no bowel cancer is good. But in terms of the significance for other family members, 55 is about the cutoff. So mid-40s.
If indeed she had bowel cancer.
If she had bowel cancer, so that would need to be verified, and then it would be very interesting to know what Joe's parent, the grandmother's child, had. Whether there was any history there, whether there'd been premature death from cardiovascular disease, or whether in fact they might have had colonoscopies and had large polyps removed, which would change the whole thing. That's then somebody who potentially Joe potentially then has 2 bowel cancers in his family history.
Because
on
if
the
they
same
hadn't
side
been
of the
screened,
family.
they would have had it.
Yeah,
Or
and we
maybe have had it.
just don't know. We can never say to somebody who's had a polyp removed, well, that was a cancer prevented. There's some times when we think that's pretty likely, but if you went into the family history a little bit more, his family history might become more significant.
So what would you do? Would you take the family history in the pharmacy, John?
No, you don't take the family history, of course, because we're involved in the screening, but the advice I would give him if he was concerned about buying it, which he isn't, but if he was, I'd tell him to have a discussion with his GP over the matter, let the GP take the history. But I think if someone comes in at 45 years of age, and I'd say, well, what's the downside of them buying a bowel screening kit anyhow? And the odds do increase of bowel cancer over 40 years of age, even though it's not the guidelines.
Sally, you wanted to ask the question now?
I agree. Well, the question I was going to say is if he has a negative result, but you've just found out that his mother was screened and had polyps, does he go on? He goes on to have colonoscopy. What if his mother? We don't know about his mother. We've got the grandmother with who died at 45. He's got a negative thing, and he's 45. What do we do with him then? With this, we don't know what his family history is.
Well, you would probably, at the very least, bring him back when he's 50 and do fecal occult blood testing every 1 to 2 years.
Just make sure he's not missed.
Yeah, that he doesn't fall through the cracks.
What's the story with flexible sigmoidoscopy? I noticed a randomised trial in the New England Journal just a couple of weeks ago suggesting that it was more effective than FOB testing. Obviously, there are huge logistical and infrastructure ramifications.
No, it's different. There's been a lot of interest in using flexible sigmoidoscopy once, perhaps at the age of 55, or even every 5 or 10 years as a screening method. And it's not competing with fecal occult blood testing. You can combine the two together. In fact, in the English screening program, they're now suggesting they should have flexible sigmoidoscopy performed at 55 and then occult blood testing from 60 through to 74.
And what proportion of cancers occur in the left side of the colon?
It's about 60%. The percentages are changing slightly, but they've shown that in 3 trials in England, the PLCO trial in the United States and the SCORE trial in Italy have all shown that in volunteers that flexible sigmoidoscopy will reduce the incidence and the mortality from bowel cancer in general, but very much so in left-sided bowel cancer. But these are volunteers, and the big question is, how would our population react to this? Would they accept the test?
So what James is saying is that you've got to multiply that success rate in detecting advanced adenomas or cancers by the participation rate if it's offered to a population.
It becomes diluted.
So it's a great interest. I think it's watch this space.
I meant to ask you earlier about information sources, places people can go for more information, Jim.
Yes. One obvious site is to the cancer screening website, cancerscreening.gov.au. And there are a number of things which can be downloaded. All the letters and all the instructions for the national program, a summary of the NHMRC national guidelines, information on family history, and again NHMRC endorsed and developed by Cancer Council Australia. And I think I showed you before the booklet, which is used in the program. But there's a lot of information there. So it's cancerscreening.gov.au.
And there's a couple of other cancer sites, Bowel Cancer Australia and Cabrini in Melbourne.
But I also say, Norman, that general practitioners are asked to send information back to the national program when they see patients who've got positive fecal occult blood tests. It's a very simple form, and it can be completed online, or you can ring the information line in Hobart, the Medicare information line, to get hard copies, or you can print copies of the report and complete them manually from the website. All you have to put in is check 2 or 3 boxes, essentially, and then return it to the program.
Norman, we've touched on family history several times, but I think we should just make the point that the NHMRC guidelines stratify the risk of your family history. So that, for example, if you have a single first-degree relative whose cancer developed at over the age of 55, they regard that as a low increase in risk. And the guidelines suggest that those people be treated as average risk individuals and start screening at age 50. The intermediate risk category is somebody whose first-degree relative was younger than age 55, or who has 2 family members on the same side of the family, whatever their age was, affected by bowel cancer. And for those people, the recommendation is colonoscopy at 10 years younger than the youngest affected relative. And then there are the FAP people and the Lynch syndrome people whose
starts at an earlier age.
Colonoscopy is much more intense and rigorous.
You're watching a Rural Health Education Foundation programme on preventing and early detection of bowel cancer, and we'll be back after this.
A home fob test could save your life.
I wish I'd done it earlier.
Fob testing is so important.
All of these people have had a long battle with bowel cancer. It's a condition that kills around 1 Australian every 2 hours.
Yet a simple home fob test kit can help prevent it.
Please purchase a home fob test kit.
It could save your life too.
I recognised her.
It was me.
Yes.
Indeed. And those were people who volunteered to give their time, and having someone as high profile as Coxie just was magnificent. And people have seen that in movie theatres, and it's pretty scary to think your face is in a movie theatre.
That's right. Put you off your shock bomb. 25-year-old Glen's a fitter and turner in a local factory. One of his workmates recently was diagnosed with bowel cancer, and they were talking about how it could be very different if he'd caught it earlier. He saw this ad on TV, and he's looking for advice, but on further questioning, he's really scared because he's been having bleeding and pain around his anus for the last few weeks, and he's also been a bit constipated. There's no family history of bowel cancer. What are you going to do for him? Well, Ambassador?
Well, I feel very strongly that I need to take his concerns seriously and not fob him off, if you'll excuse the pun.
Yes.
But he's got some symptoms, and I need to investigate what that is in terms of having a look at him, examining him, and seeing if I can actually see any evidence for his bleeding. 25 25, his risks, if he's got no family history, his risks are very low. If he's got pain and he's got, obviously it sounds like he's got an anal fissure, I'm not going to stick my finger in because it's going to be too painful. But again, here's another example where I would treat his symptoms and the signs I'm seeing and then get him back and talk about it again. I'd also give him some information on bowel cancer.
Cameron, take me through the history taking of bleeding. What's worrying, what's not, when you can relax, when you can't?
Well, it's a minefield, basically. I
red
guess
one.
at the lower end of the concern spectrum is small amounts of fresh, bright red blood on the toilet paper only, not mixed in with the stool, and particularly if a patient tells you that it's been happening on and off for years and years and years unchanged. At the other end of the spectrum is heavier bleeding, particularly if it's dark maroon coloured blood, suggesting that it's not from low down in the anorectum, particularly if the blood's mixed in with the stool, and particularly if it's a recent development. It's a minefield though, and we talked...
But a low cancer will give you fresh bleeding that looks like a hemorrhoid.
Absolutely, and as Sally said, no one should be fobbed off. And unless her symptomatic patient, Joe, responds immediately to treatment for his anal fissure, I'd have a low threshold to investigating someone like that with sigmoidoscopy.
He doesn't deserve a colonoscopy?
I wouldn't sigmoidoscope. I wouldn't colonoscope him because he's got symptoms that all sound as if they're within reach of a sigmoidoscope.
And if he was a litigation lawyer?
I'd still do exactly the same. I'd treat him like he were my brother.
But yeah, I'm just getting a little nervous that you're all a bit relaxed about bleeding.
No, I'm not relaxed, and but I think in somebody like him where there is no issue about bowel cancer screening, we're talking now about a symptomatic patient, and flexible sigmoidoscopy is adequate investigation of this guy's symptoms.
So FOB is not an option in him. You would go straight to...
No, he's symptomatic.
Well, he's got bleeding, so the thing is, though, that he's 25. If I'm in like downtown suburban Sydney or Melbourne, I can send him off to have a sigmoidoscopy. But if I'm in a rural area and he's 25 and he's a fitter and turner, surely I would treat... it looks like an anal fissure, it smells like an anal fissure, it quacks like an anal fissure. I'd treat that and then get him back and review him and say any more bleeding without the anal fissure and off you go. But I'd give him a couple.
To what extent do you only get bleeding once and that's the only sign you've ever got?
And have bowel cancer?
Yes.
It certainly can occur. Many bowel cancers are silent. And certainly silent until they have reached an incurable stage.
But once you've got the bleeding, are you likely to only have one episode, or is it likely to come back again? I'm just thinking, this young man, I know what you're getting at there, Norman.
It's possible.
Oh, thanks for that.
Well, I'm getting at investigating symptomatic people. That's what I'm talking about.
Yes.
And
Notwithstanding the low risk of finding something.
And I fully agree that we do have to take this very seriously.
Yeah, but logistically...
Most early stage cancer causes no bleeding at all, no symptoms. It's silent.
But a 25-year-old guy, I mean, where do you draw the line? And especially, what are we saying to people in remote areas?
I'm talking about a 65-year-old guy.
Yeah.
But we do, and this is another misconception from both the general public and as health professionals, that we are seeing young people with bowel cancer, and a lot of the young people we're seeing coming to Bowel Cancer Australia are telling us that we had visible bleeding. We thought personally it was hemorrhoids, so we didn't worry about it because they were either pumping weights, taking a lot of protein, and these are the issues that we really need to get the message out there that young people can have bowel cancer.
But I guess we've got to put it in perspective, haven't we, Tammy? You know, every year, Norman, 14,000 Australians get bowel cancer. Of that 14,000, 1,000 are younger than age 50, and less than 80 are younger than age 35.
The point here, though, is at 25, you just don't lose them to follow-up.
No.
You presume it's an anal fissure unless there's those worrying signs of bleeding. I'm just going to be absolutely clear on this, but you get them back. You don't lose them to follow-up.
Fully agree.
So you make sure your receptionist reminds you in a month's time to phone him up and find out how he's going.
And he's a young guy, he might have inflammatory bowel disease.
If he's 55, even though you think it's an anal fissure?
I'd think about his symptoms, and if they were still distal, to investigate his symptoms, I'd do a sigmoidoscopy. But if it's going to make fecal occult blood testing, if he's an average risk guy, if it's going to make fecal occult blood testing impossible, and I'm not sure that you can rely on the fact that the visible blood disappears. I think it's possible after a fissure heals up, or if someone has hemorrhoids, it's still possible to have bleeding related to anorectal pathology to make the FOBT unreliable.
Cameron, when you say sigmoidoscopy, you mean flexible sigmoidoscopy?
Flexible sigmoidoscopy.
So examination of the rectum, the sigmoid colon, and into the descending colon.
Yeah, but my point then was, if this is a 55-year-old guy where you can't assume the disappearance of visible blood means that he can have an FOBT, then probably he needs a colonoscopy.
Okay, just very quickly on colonoscopy, we're running out of time. Colonoscopy,
Yep.
current bowel preps and so on, just give us a flavour, so to speak, of
Look, they've improved.
What you do now for...
They've improved, but they're still not ideal. So generally there's several days of avoiding high roughage things, particularly things with seeds. So while they're good for the bowel normally, muesli, multigrain breads, etc., avoid those for 3 or 4 days beforehand. Clear fluids the day before. And then a bowel preparation that's 2 or 3 sachets, and it depends a little bit on age and absence of comorbidities like heart and renal disease. But for most people under the age of 70, 2 small volume doses and a large volume dose is my standard preparation.
And we've got some graphics of polyps just so that you can see what happens there. So just what are we looking at there?
So there's on the left of the screen is a sessile polyp. That's not particularly big. On the right is a pedunculated polyp, and both of those would be easily removed at that colonoscopy. At the colonoscopy that they were detected at, they could be removed with a snare, and that's a pretty straightforward procedure. They should always be they should always be collected, and they should all be sent for histopathology.
A couple of quick case studies. 52-year-old woman comes in to see you, Sally, and she's just back from looking after her sister who's a year or 2 older, who's just had bowel surgery for bowel cancer.
That's easy. I'd send her. She's got a family history of her sister's young. I'd send her straight off to have a colonoscopy, bypass FOB.
And another case is a 65-year-old woman who's living in Queensland, comes to see you feeling very unwell. She's overweight, a smoker, drinks alcohol on a regular basis. She's been suffering from diarrhoea, bloating and cramps, feeling a bit fatigued and vomiting for a week.
There's so many things she could have. She needs a complete workup. Obviously, I'm going to have my bowel cancer sitting there in my list of differential diagnoses, but there's so many other things that I'd need a full workup with her.
And you'd probably include some iron studies. And if she's
Absolutely.
iron deficient, in a younger woman, in a premenopausal woman, there's a little bit of room for manoeuvre, but in a postmenopausal woman or in a male, iron deficiency is a red flag.
And if she has cancer, it's not going to be good news, is it, in her?
Well, if her symptoms are due to bowel cancer, her prognosis is worse than if she's found to have an asymptomatic cancer, say as a result of screening.
Just remind us of the staging. We're still into Duke's classification?
No, we've moved on, and there's a tumour node metastasis classification that yields a stage 1 to 4 that roughly correspond to the A, B, C and D of the old Duke's classification. So the A and the B are variably involving bowel wall only, C or stage 3 involving nodes, and stage D or 4 involving metastases to distant organs.
And the outcome of surgery?
In the first stage is very, very good. According to as is illustrated on the graphic, in stage 1 disease, 5-year survival rates are around 90%, and they progressively fall as the tumour involves deeper into the wall, then the lymph nodes, and then by stage 4 with metastases present, the 5-year survival is something like 5 to 8% only.
And adjuvant chemo, I mean, GPs need to know this because their patients are going to come back. Adjuvant chemo is routine now?
No, its clearest role is in stage 3 disease, so when lymph nodes are present. It's a little bit more it's unnecessary in stage 1 disease, and it's more controversial in stage 2 disease. So where the cancer is a little further through the bowel wall but not yet involving lymph nodes, and that's quite a complex decision.
Just let's go through, I know we're running out of time, 2 or 3 quick questions from our audience. Carol from Tamworth asks, is chronic constipation a risk factor for bowel cancer?
No.
April from Toowoomba asks, does a vegetarian diet protect you from bowel cancer?
No, not necessarily.
But you're not eating red meat.
No, that's right. It's
I thought Seventh-day Adventists had a lower incidence of bowel cancer.
I can't tell you on that one.
Yeah,
I think they do.
But in terms of I know vegetarians who have actually had bowel cancer, so it's something that you can't rule out.
Sure, it doesn't mean to do it, but when it's same with exercise, plenty of people who take regular exercise get bowel cancer. It's just
That's right,
you're
but it
lowering
is reducing the risk by minimising your red meat intake.
And Andrew from Alice Springs asks, is there any evidence that an infective agent can contribute to the development of bowel cancer? Not a silly question.
I'm not aware that there is an infection that increases the risk of bowel cancer.
But is that sort of epigenetics? Are we starting to get into epigenetics there?
Well, not necessarily. I mean, we said there was no chance of it in stomach cancer, and we know that H. pylori is related. It's not a silly question.
But the common bowel infections, things like Salmonella, Campylobacter, Shigella, don't predispose to subsequent.
Yeah. Well, thank you all very much. Been fascinating. Sorry it's been a bit rushed towards the end, but we don't want to get to that stage of that lady at the end, by the way, where she's got spread and you're really trying to struggle to get to any good result at all. What are your take-home messages, Jim?
I'd like to say that with the National Bowel Cancer Screening Program, we know from the BioGrid study, which has been run with the Colorectal Surgical Society of Australia, that the people diagnosed through the program are far more likely to have stage 1 disease, 40% if not more with stage 1 compared to those who present with symptoms where it's 14%. And with distant spread, very few, 3% had metastatic disease compared to it was 15% in those who presented with symptoms. So we're already getting early stage cancers,
a powerful story,
which should translate into better survival.
Tammy?
2 points. Really, for those listening, don't underestimate modifiable lifestyle factors. I think taking the time to talk to people in terms of what they're currently doing and the changes that they could possibly be making to improve their health is important. And also to talk, test and tell. Talk about bowel cancer, test for it if you're within the age groups or if there are symptoms, and tell your family if it is in the family.
Sally?
Well, I think as general practitioners it's up to us to sell the message that this is an insurance policy, that it is the only cancer that we can prevent other than the vaccinated, other than cervical cancer with vaccination. And I think work in partnership with our pharmacy colleagues that together we should be able to make sure that people live.
Yeah. Well, sort of in rural areas, it's often hard to get in to see a GP, so they can pick the test up at the local pharmacy, and if they're positive, they're referred back to their GP. So that's the arrangement. And I think, you know, in that age group, you don't have to have the symptoms to have the start of the cancer, and so get tested often.
Cameron?
Everyone over the age of 50 should do something to reduce their risk of bowel cancer. If they're asymptomatic and have no family history, a fecal occult blood test every 2 years. If they've got symptoms, get them investigated, and if they've got a strong family history, have a colonoscopy.
Thank you all very much indeed, and I hope you've got a lot from this programme of beating bowel cancer. Let's get those mortality rates down. And if you're interested in obtaining more information about the issues raised in tonight's programme, there are a number of resources available on the Rural Health Education Foundation's website. That's at rhef.com.au. Then you can go to the Beating Cancer Prevention Detection Treatment Programme webpage and click the resources link. If you're a health professional, don't forget to complete and send in your evaluation forms, which can be found on the website. You will receive a certificate of attendance and, if eligible, CPD points. Our thanks to the Australian Government's Department of Health and Ageing for making the programme possible, and thanks also to you for taking the time to attend and contribute. For more information about the Rural Health Channel on 600, you can find that on the Foundation's website, rhef.com.au/RHC. I'm Norman Swan. I'll see you next time.